Hello, good evening, everyone. This is Dr. Shaher Khan from Novi, Michigan. I just want to go ahead and welcome each and every one of you to another Facebook Live session. So hopefully you find this informative. Just briefly, I'll go ahead and wait for some guests to join us. I am a board-certified general surgeon and also a board-certified plastic surgeon. I've also specialized in burns. And I want to go ahead and address breast implant illness, which is a real entity, a real problem. And what I say and what I have said in the past, basically a defined solution to what would be a problem, which is a removal of all the toxins, the impurities that are the implant itself, plus also the capsule that is directly surrounding the implant, plus any inflamed tissue that will be encasing or in the proximity of what is the breast implant itself. Now, having said this, there are a lot of different topics that I want to talk about. I want to go ahead and discuss with you the many cases that I have done. Just briefly, I want to go ahead and welcome each and every one of you, the new guests, the new members to my private breast implant illness support group. This is a public page that I'm basically discussing on so that I can reach the masses, not only my patients, my prospective patients, but also many other physicians, medical students, whoever it may be in the allied health, the spouses, significant others, who may be interested in learning more so that I can spread the word and I can discuss with you how I, as a board-certified plastic surgeon, look at breast implant illness so that I can share with you what is essentially my practice of removing implants. This is essentially 90-95% of my practice now. And as you will see, there are patients that have come to me literally from all walks of life, different ages. Just within this week, I have operated on Monday morning, for example, on a patient who had a set of implants from 1976. And this was her first set that she had. And going into the surgery, given the patient's medical comorbidities, she was on home oxygen, given her lung issues. And also she had history of DVT, which is the deep vein thrombosis. She was on Coumadin, which is a blood thinner. And per discussion with her hematologist, and also her team, when I got the clearance, it was best decided that she would be best taken care of at the hospital setting, where just in case, God forbid, there was any need post-op or intraoperatively, then there was many other tools that would be available along with the many teams at the hospital. So I was able to offer her the same surgery that I would offer the many other ladies that come. For example, the 30-year-old that I operated today that came from Colorado. And so she got the same surgery that patient, the 72-year-old that I operated on Monday, what the 30-year-old got in my private surgical suite this morning. And the point here is the whole gist of this conversation, the whole gist of this Facebook Live is the fact that the entirety of the implant plus the capsule plus any inflamed tissue must be removed such that post-operatively the body is in equilibrium and in harmony such that there are no toxins remaining behind and the body has a chance to bounce back to a normal good state of health minus the toxicities. We know this definitively because if you look at the pathology reports, you will see the pathology says foreign body reaction, giant cell reaction, histiocytic cell reaction, refractile material, chronic inflammation, all implant particles within the capsule itself. You don't want to just naively remove the implant itself, leaving the capsule behind. Otherwise, that small burden that's remaining within the capsule itself will continue to trigger the immune response, and hence the breast implant illness symptoms will continue and persist. They might be improved somewhat, but not eliminated definitively, and maybe the brain fog might not be as bad, but might continue to linger on. Why do we know this? We know this of the many patients who have had the implants removed, but the capsules left behind, they continued to have their many breast implant illness symptoms till they went in for a second surgery just to exclusively remove the residual capsules, and then only did the patients bounce back to a normal good state of health. And this is exactly what is the gist of what is explant surgery. So your surgeon must know in their mind definitively, convincingly, they should be completely, faithfully committed to removing the whole capsule, because it is that commitment that determines with certainty that post-operatively the patient can look the surgeon in the eye, and vice versa. The surgeon can look in the patient's eye and say, we got 100% of the capsule out and 0% of it remains behind, and that your body is now going to be hopefully in equilibrium and it will bounce back to a normal state of health minus all those toxins. So that was the case that I did Monday morning. The following day on Tuesday, just this week, a couple days ago, I did a 69-year-old lady with a set of implants from 1973, silicone. This was my second Facebook Live that I did, that you can see on my public and also my private page. A set of implants below the muscle, silicone from 1973, 38 years ago. She was relatively healthy. She had rheumatoid arthritis for the last 25 years or so on Humira, methotrexate, and immunomodulators, along with her age and obviously the inflammation. And she got the same surgery that the 30-year-old from Colorado did. So I was busy Monday, Tuesday, Wednesday, and I have a couple more cases tomorrow as well. And so this week I've been relatively busy with explants, and again, complicated cases. And again, the whole gist of the surgery being that the entirety of the implant plus capsules must be removed. So today, so on Monday, I did a 72-year-old lady with a set of implants from 35 years ago. On Tuesday, I did a patient 69 years of age with implants from 1973. And today I did a 30-year-old with a set of implants from just 2019. So she had implants from just 2 years ago. So you can see the many different patients. The week before, I operated on 2 sets of patients who had residual capsules. And the task and the goal of the surgery was to remove the residual capsules such that the patients would bounce back to a normal good state of health, because after removal of the implants for those 2 patients where they had residual capsules, they were not feeling better. And this is the last thing you want. You don't want to undergo a second surgery just so that you would go ahead and get the residual capsules removed. So the 100-100-0 rule, which I have mentioned before, must apply, which is 100% of the time, 100% of the capsule must be removed with 0% of the capsule remaining behind. Also, as you have mentioned, the way your surgeon should do it, it needs to be done in a very determined, meticulous way such that the entirety of the capsule is removed. And what are the different criteria that I say that kind of ensure or indicate that the surgery was done right? Number one, the length of time. You cannot do this explant in an hour. I, on average, book my patients for 4 hours. That's usually approximately plus minus the length of time it takes. Number two, the length of the incision needs to be approximately the diameter of the implant itself. You cannot remove a 700 cc implant from like a 3 centimeter incision. So you can only imagine the larger the implant, the larger in the incision, and the implants literally should crawl out. It should not be wrestled out of the body. Number three, the pictures need to be taken not only of the implant plus capsule on the table and then cutting, but also a video of the chest wall itself showing that the entirety of the implant plus capsule was removed such that there is no capsule remaining behind, because that's the ultimate of all the proofs that there is no residual capsule. And plus, this goes back to the next point. The implants need to be returned to the patient. So just today, the first patient came in, and the history, the patient stated to me that she had textured implants. And lo and behold, when I did the case, she had smooth mentor implants. So again, the implants need to be returned to the patient, so the patients know that they were returned. They were basically removed without damage. For example, saline implants were not popped and removed for the convenience of the surgeon, because you do not want that saline to basically go within the body and be absorbed, for in it are the toxins. And number five, the reputation of the surgeon. Your surgeon must wholeheartedly, faithfully commit to you that they're not going to try, or they're not going to make an attempt. They will see. They need to be 100% determined that the entirety of the implant plus capsule is removed, and they need to have what is now called, or what is considered to be, the attestation by the previous patients that the surgeon has done the due diligence and has a track record on social media. The old patients who basically can attest to the fact that the surgeon is committed to removing the whole capsule. And you will see after some time, it doesn't take much reading or talking to the old patients as to what type of an experience you're going to have. There are some surgeons, unfortunately, who will say, well, the patient is on an immunomodulator. For example, the Humira patient that I did on Tuesday, which is a strong medication that suppresses the immune system. If a patient has rheumatoid, or for example, another Crohn's disease of ulcerative colitis, that patient should not be compromised in removal of the capsule. So for example, I heard one patient say, my surgeon told me, because I am on that strong medication, he will not remove the capsule off of the rib, which is absolutely no. There should be a total commitment, regardless of the age, regardless of the comorbidities or the blood thinner. Just like my Monday patient, the patient needs to and must get the exact same surgery. Otherwise, you don't want to remove part of the burden. You need to do the right and definitive surgery. And when done, it can absolutely be done right in a safe manner possible. Let me go ahead and also share with you, a couple of weeks ago, I had a patient that came to me. She was all set ready. She had cardiac issues, specifically atrial fibrillation. And I needed to get specific clearance from the doc that she was good, her heart was good for the surgery. And I absolutely do not want any surprises on the OR table or thereafter. So for the patient's own good, I find out on the day of the surgery that the patient had what is called cardioversion, where they essentially shock the heart and jumps the heart up. The patient is sedated and is basically put to deep sleep, and the patient's chest, i.e. the leads, are put on, and the patient is essentially shocked in order to jumpstart or reboot the heart's electrical system. That is a pretty adverse event. Just 2 or 3 days before the surgery, sometimes that can lead to leak of the troponins or cardiac enzymes, and that is an absolute contraindication, canceling of the surgery, because I don't want the patient to bounce back into RVR, which is atrial fibrillation with rapid ventricular response, because that could potentially be an emergency. So all of a sudden, the case is canceled for the patient's own good. Now, the cardiologist needs to understand that you cannot directly undergo a procedure. Another patient that I just talked to yesterday, she is a fine nurse. I needed clearance given her cardiac issues that she very well brought to my attention, and the cardiologist determined that she would be best served at the hospital because that is the right setting for that patient, and the outpatient surgery setting was not optimal, and for that reason another patient now has been determined to be wise and safe to proceed at the hospital. So the point I'm trying to make here is surgery is involved. Selecting the patients is basically also very involved, and each and every single detail adds up, making sure that the patients continue in their nice state of health before surgery, on the day of surgery, and thereafter, so that the stress of the surgery, it does not decompensate the body such that the patient basically goes into worse health. What could be worse? A patient on oxygen and also on a blood thinner that I operated on Monday, and relatively safe. This is not, when controlled, determined, optimized, the hemodynamics, making sure everything is done right. A surgery that can certainly be performed still as an outpatient when all the teams are on board and the patient has undergone a cardiac clearance. I also want to emphasize that post-operatively, it is imperative for the patients to follow through with the instructions. As you saw on the Facebook post earlier, a couple of days ago, the patient had discharged. Now, as you can imagine, the pectoralis muscle sits on the entire chest. For example, on the right side, and it inserts into the humerus. If you Google the pectoralis major muscle, The origin of it is over at the sternum and also on the lower part of the chest where it anchors, and then it inserts into the upper arm, the humerus. So if you flex your arm like this, you're going to find you're going to activate the pectoralis. The goal here is if you reach for the upper cabinet, or if you move a heavy door or lift a heavy object, even just once, for example, you're going to find that is going to inevitably put stress and strain on the muscle itself, may cause it to bleed, may cause it to hurt, spasm, may cause a seroma if it's done repeatedly, or may even cause a hematoma. And so it is important for the patients, what I talk about specifically the T-Rex arms, if you have your elbows against your waist, you could type, text, make a cup of coffee, a sandwich, type for 8 hours, no problem, because you're not limiting, or you're limiting yourself such that your pectoralis function is totally not used, and you have other muscles of the upper arm that are now utilized, and you don't want to activate the pectoralis muscle because this is the muscle underneath which the implant was, and you don't want to move it. Otherwise, it will be irritated and it may spasm. It may essentially put stress on the sutures. And what it does is, remember, I use 4 layers of suture. The vicryl suture 3/0, another layer of vicryl 3/0 suture. So that's 2 layers at the bottom that incorporates the scarpas and the deep dermal. And then I have Stratafix. That's the second last layer. And then the topmost layer is also the Stratafix, which runs back and forth. So for 4 reinforcements. Now you can only imagine if you reach for the upper cabinet, twist, turn, move, you have a lot of shear forces on the incision, and just a small hole will be enough for basically fluid edema inflammation to leak through, as can be expected, for example, after a tummy tuck or a gynecomastia surgery. So it is important that the compression be there. I put the picture out of that gynecomastia patient. You can imagine he had a lot of fatty tissue and a glandular tissue that was removed. And again, just like with the tummy tuck patients, just like with the gynecomastia patients, and likewise what is with the explant patients, you want nice good compression on the chest wall such that that void, that space where the 2, 3, 4, 500 cc implant was sitting, now that muscle gets the chance to sit back right on the chest, which takes approximately 6 weeks, and that big void where the implant was gets a chance, i.e. the breast tissue, to sit tight against and adhere. And in a matter of doing so, the dead space is addressed definitively. How would you feel if you got a tummy tuck, for example, and you don't have an abdominal binder and you move around? Now you can, or for example, a gynecomastia surgery where you have male breasts, for example, that are removed. 6 weeks of compression is textbook answer, standard of care. And so likewise, I do 3 weeks and 3 weeks depending on the patient. Today I talked to a patient from Virginia, and she was graduated, I believe, in approximately 10 days to no binder at night. And now I have her at the 3-week mark moving around minus the binder. Now she's very different compared to the many other patients, and this is why I talk to my patients regularly once they have been discharged after their 4 to 5, 6 day stay here in Novi, so that once they're back home they feel comfortable and confident in regards to their recovery. So on average, the patients, for example, if they do come from out of town, I do the surgery on Tuesday. Most of them either end up leaving on Friday morning once I've seen them, or on Monday, the following day at the 6th day, post-op day number 6, where a lot of time has elapsed and I feel comfortable and confident sending the patients home. And I request the patients to get, if they're flying, to get travel insurance, so that if they have to plus minus the 2-3 days, they absolutely this is not going to be an inconvenience, and no charge per airline insurance slash insurance that they can buy. The most I have had anyone stay was a lady that came from Los Angeles. She flew in. She was a lady in her 50s. She was on prednisone 5 milligrams for the last so many years. and given the suppression of the inflammation that she had all over her body. And also she had 800 cc implants after what was a breast cancer reconstruction. So you can only imagine the third space, i.e. the prednisone delaying the wound healing. And plus she was part of a documentary series. I wanted to be absolutely certain so that when she would head back to Los Angeles, she would be comfortable and confident about her post-operative recovery, and everything went well. Now, I want to mention, I talked to a patient this last week. The largest set of implants, just, the many different patients that I've talked to. So she had 800 cc implant saline, and the doctor who inserted them added another extra 400. So she now has what is a 1200 cc implant on each side. So you can only imagine the type of dissection, the post-operative skin access, along with the dissection directly off the rib underneath the muscle, and how complex and difficult she would be. Another patient that I talked to was a tram flap. She had abdominal muscle that was rotated up into the chest, and she is going to have her implant removed along with the capsule without disturbing the tram flap, given her history of mastectomy. Now, what I'm going to do is, let me go ahead and look at, I want to go ahead and mention, there's a patient that I'm going to do next week. She had 2 sets of implants. One set was above the muscle. A few years later, she had a second set of implants below the muscle. So she's going to be a relatively more involved patient for the fact that I would remove the implant plus capsule below the muscle. And then once I'm done, I'm going to remove the first set of capsules that she had from above the muscle, so that she has all the capsular burden removed, which is an important part of the surgical procedure, because leaving that capsule behind from the first, the entirety of the capsule must be removed from the first set and the second set, because I do not want to leave any burden behind. Otherwise, that will continue to haunt and tax the patient. The other thing I want to mention here is, if you take full thickness skin or partial thickness skin, the skin has an amazing ability to contract, especially full thickness, almost 30 to 40%, depending on the genetics, the age of the patient, sun damage, alcohol, water intake, along with the different medications, for example, prednisone, which alters the quality of the skin, that factor in. So the point here is that you will see, just like that gynecomastia patient that I posted earlier today or yesterday, the skin, along with the breast tissue itself, has what are ligaments that help recoil, contract the skin along with the breast tissue, such that once the implant is removed and the inflammation subsides, the breast tissue, in approximately what I would mention, 80% of my patients, recoils to a very satisfactory state where the requirement for the lift or the mastopexy is not there. I want to go ahead and mention briefly what many patients come and state that they want to go ahead and get what is the Khan procedure, which is what and how I do differently compared to what the other surgeons do. This is where, number one, I basically exclusively do not use drains. There is no need for the drains. And once the surgery is done right in the avascular plane, as you will see in this couple of videos that have been put up, the dissection is done in a very nice sophisticated plane such that the blood loss is essentially minimal. Number two, I return the implants to the patient. That is very important so the patient sees that there is definitive closure, and she can match it to her lot number, and she can state and see that the implant, what the quality of the implant is. Number three, I take cultures for aerobic, anaerobic, and fungal, and absolutely making sure that there is no bacterial burden that was left behind or was a part of the implant. Sometimes a capsular contracture can result. We want to rule out bacteria that are associated with implants. Number four, I take pictures not only of the implant capsule, plus also the chest wall, showing that the entirety of the capsule was removed, because that is the ultimate of proofs that you want that everything was done right. Number 5, I send the capsules off 100% of the time to the pathologist, so the pathologist can look at it and rule out breast cancer, rule out lymphoma, which is the BIA, breast implant associated anaplastic large cell lymphoma, where they do a CD30 analysis. They rule out any abnormalities, look at the many different cells that are associated, the refractile material that might be present, along with the calcium/silica. So that is important. Number 5, I do what is the twilight anesthesia, which is the deep sedation or the monitored anesthesia care, where the patients are in deep sleep and they are not necessarily paralyzed, or they have a machine that's breathing for them, because that is what I would say not required. That's overkill. If you can achieve it safely, efficiently, with basically excellent anesthesia that does not require a machine, i.e. the same ventilator that would breathe for the COVID patients to breathe for the patients, and there is a safer alternative and a very effective alternative. You can see to date, almost 100% of my patients, I can state, have had a very good intraoperative experience when it comes to this type of anesthesia, and this is what I recommend to my colleagues, that they exclusively do for general anesthesia with paralysis, and machine breathing for the patient is not absolutely and not necessarily, unless required. So now what I want to do is I want to have my guests ask me questions. This way I can help you understand better what is the reason how I do things. I want to mention, there are a lot of questions people ask me about detox, and I will say, there are a lot of people, who basically invest in a lot of different products, for example, infrared sauna, or the charcoal. And I will say this is all inconclusive. This is not true as far as an MD. If this was true, then you would be getting better and not having to basically do the surgery. The best and the only detox that I find is that the patient get the right surgery, where the entirety of the capsule plus implant is removed, plus any inflamed tissue, such that none of that burden is left behind, and you basically get a chance to bounce back to a good state of health. So this is, drinking celery juice is good because it has all the antioxidants and along the benefits of what are in fruits and vegetables, avoiding basically oily, greasy, carbohydrate, high fructose type of foods. All of these other modalities, vitamin C, if you have basically an orange a day or a lemon, half a lemon, that's your vitamin C. You don't want to get vitamin C toxicity. You can certainly, these medications are not regulated by the FDA, and some of them are pure chalk or a very high concentration. Same thing with probiotics. How many millions of colonoscopies have been done? Where do the gastroenterologists say that you have to take a course of probiotics, or the people who have diarrhea do the and it has been shown that probiotics actually may be detrimental. Same thing with these many other chemicals, i.e. the patients are taking. Now, omega is good, fish oil is good, turmeric is good, anything high fiber is good. A pill, vitamin D, calcium, postmenopausal, for the osteoporotic, or even regular, both for men and the ladies in their 50s and past. Certainly that is good health, and you can certainly measure the vitamin D level and the calcium levels and make sure that you have a good level in the body. And you can also certainly do a bone density test to confirm that your bone health is good, but not taking it if you're in your 20s or 30s, for example. That might be overkill, or that might lead to deposits of calcium within the body, or kidney stones, things like that. Now, I see a question here. Do you recommend physical therapy after healing? Now, I will tell you, so muscle in itself, given the pectoralis underneath, which majority of the implants are, that muscle in itself, once the surgery is done, it settles down in approximately 6 weeks. After the 6 weeks, I have the patients get, for example, 3-pound weights and start flexing gently at the elbow, and then also kind of working the arm such that you're moving the deltoid and upper arm. Now let's look at the pectoralis function. I want the patients to kind of do the exercise themselves such that they gauge and they get a feedback, their sixth sense is to go slow and not push themselves. So you will find that many ladies, after their 3-week conversation with me post-operatively, they're finding themselves doing a little bit more active and more free, just because they feel better, energetic, and they feel they're more out of the surgical phase. And I tell them wait for the 6 weeks, because at the 6-week mark, plus minus, and again individualized for every patient, I have the patients flex and extend the 3-pound weights like 2 minutes in the morning, 2 minutes in the evening. So now the patients are actively building the muscle. And I tell them to listen to their sixth sense. If they feel like they're overdoing it, or they're basically feeling the stress of that active muscle building, then I want them to slow down for another week or two. And during the 6 weeks of recovery, all the drawers that one has opened, or the weights that they have lifted, or the iPad or the plates and the coffee mug and all those passive movements, they have led to the healing and now build up on the exercise. Now once you go to, there is no requirement for physical therapy is basically the short answer, because you will be able to do all of that. At the 6-week mark, I have my patients go swimming. They can start gentle yoga and work up, and then incrementally reach a level that they feel comfortable, such that now the pec is truly being used. Because if you can imagine, once you had the implant, you truly as a patient were not using your pectoralis, because the pectoralis muscle was compromised. Anytime you would lift something heavy, like for example rearrange furniture or lift a heavy bag, the pectoralis muscle would push the implant against the chest, and the patient would stop reflexively because they would feel uncomfortable. The implant would push against the chest because the pec would push it down. So all the time the patients have had the implants below the muscle, the anterior shoulder burden has been there, and the anterior stabilization, because of the way the pec sits and inserts into the humerus, if this is the insertion point, that has been weakened, and now all of a sudden there is unopposed back pull, and hence what would be a secondary back neck problems, along with the trapezium strain because of the weight of the heavy silicone. Now the point here is, once the 6-week mark occurs, you can go swimming, exercise, and build not only the pectoralis major, pec minors, the deltoid, serratus, all the muscles of the shoulder, and the latissimus, and now you're going to be able to use your upper arm like never before. And so truly the need for the physical therapist is not there, because the best therapist is you. And you will work up then incrementally to a level where you're going to feel safe, and then maybe at the 4 to 6, 8-week mark start, say for example kayaking, things of that sort, where you're listening to your sixth sense and then working up incrementally in that order. Now if I can answer any more questions, that would be great. Normally I'm so busy, I see a lot of questions come, and I tell myself I'm going to go ahead and answer on the Facebook. And then the next thing you know, it's time, it's getting late, and I'm not the best of the typists when it comes to using the phone. I'm still, believe it or not, trying to get used to Facebook as well. Now, what I'm going to do is, I want to go ahead and emphasize, before the surgery, you want to go ahead and what I want you to do is, I'm very detailed, particular about getting the cardiac or the clearance from your doc, making sure that you're in good sound health. I want the patients to have had a COVID test, just so that the COVID would not be a burden for them post-operatively. And that you basically have stopped all supplements. Now, supplements means that are herbal medications. You can certainly run them by me, and I can tell you which ones to avoid, which ones to take. But on average, majority of the supplements I do not want the patients to take. Sometimes the patients come and they have a bag full of 20 medications, and none of which that I know a name of, because they're all foreign, or they have a unique combination order to them. Because I truly do not know, and neither do the patients. And I assure you, if you get a chemical analysis of those herbals, they're going to be different in the different bottles, because they're truly not regulated, unlike the medications that you get from the pharmacy. So now what we did was we put out like a series of before surgery what to do that is relatively self-explanatory, on the day of the surgery what to expect, and then after the surgery what to expect, and discharge written instructions are given. Now the next question I see is, when can we sleep on our side after the explant? So once the surgery is done on the chest, you can only imagine with the bra and the binder on, you can go ahead and put 2 or 3 pillows, whatever you feel comfortable, such that your head is elevated and that there is no undue stress on the chest. If you want to, if you're a side sleeper, you can go ahead and hug a pillow and turn to the side. Given the compression you have from the bra and binder along with the pillow, you're going to be okay, especially if you have to cough, things like that. So absolutely, some people go ahead and sleep on a lazy boy couch, for example, or they get like one of these pillows. You don't have to do that. Just putting your head on 2 or 3 pillows and with the head of the bed elevated at a 20-degree angle, that's good. And if you want to sleep on the side, you certainly can hug a pillow and sleep on the side. That will give you good compression and also the comfort that you need so that you can sleep on your side given the recent surgery that you had. Now, what I want to address very importantly, the other questions that I have noted from a lot of the Canadian patients, for example, that they call, oh, my insurance is covering. Or one of the other patients, well, I just found out my insurance is going to cover. Well, the first thing I want to mention here is insurance coverage reimbursement is essentially nil, minimal, and will never justify what would be a 4-hour commitment by the surgeon approximately because of the length of time, the commitment, and this, you're looking at a financial a professional fee that is reimbursed. You're looking at approximately, depending on the insurance plan, if this is not part of the deductible, you're looking anywhere from like $500 to $1,200 on average, $800. And I'll tell you, no one will spend that qualitative time and that commitment to basically removing the implant plus the capsule, the care it needs in order to do the surgery right. If that is what your surgeon is committing, the next thing I want you to go ahead and see how long is the patient committing due to surgery. I want to go ahead and also emphasize the point where if you look at the pectoralis muscle, correct? Majority of the implants are below the pec muscle. The entire explant surgery that I do, for example, the one that I did today, where I started approximately 7 in the morning, I didn't get done till approximately 3 o'clock with my 2 cases alone. The point I'm trying to make here is I cannot fast forward or do the surgery in an hour, hour and a half. It just takes me the approximate 4 hours. I would say almost a good 2/3 of the time I'm running over or past the 4-hour mark. And the entire surgery that I do, the explant surgery, is done below the muscle, which is a 4-hour commitment. If a patient comes to me and says, do a mastopexy or a lift, that surgery is all above the muscle because that's where the nipple areola, the breast tissue, and the tissue rearrangement that's going to be done. And in order to do a true lift or a mastopexy, which usually on average lasts 10 to 15 years, that surgery in itself is a 3 to 4 hour commitment. And someone, for example, who had no implants and she wanted just a mastopexy or a lift. And the point I'm trying to make here is if you do the 2 surgeries, that at least be 6-7 hours. And this is not what I find or the other patients find is being done, because the whole emphasis, unfortunately, is done on a lift, where vast majority of the patients will do relatively well minus with no need for a lift. And the point here is this operation needs to be staged. The whole emphasis of the surgery needs to be on doing the right and the best and the perfect explant with a total commitment by the surgeon. And the legal bind that the patients have with the surgeon is on that consent form, which specifically states capsulectomy, 100% capsulectomy in the en bloc fashion, or 100% capsulectomy that is going to be performed. Period. Because this is what the legal bind is. If you write down capsulectomy, it may be a partial capsulectomy, or you could remove 10% and that could be a capsulectomy. So you have to have a surgeon who is very proactive, preferably on social media or online, who says, I believe in breast implant illness. Over the break, there was a patient that was operated on by a surgeon who said, I don't believe in breast implant illness, but I will do your explant. How can you do that? You have to believe in something in order to do the surgery, right? Otherwise, you're not going to do it because you don't understand, you don't comprehend what exactly it means. So the point here is your surgeon has to have that faithful commitment that BI is real, and ideally the true surgeon who is going to do the best and the right surgery, who's truly devoted, sincere, empathetic, who is truly wholeheartedly on board, is the surgeon who does not augment. And I will tell you now, 5 years ago, 7 years ago, no one knew about what is BII. I will tell you, as a med student, I knew in 2003 that I was not going to be basically augmenting because of all what I saw. You spend some time with me in clinic, you will be aghast and surprised as to what and how. Look at those capsules that I opened on Monday and Tuesday, right? Once you see those, I cannot imagine anyone who would, in the right frame of mind, say, I want implants. They will probably feel disgusted. So on Monday, just to let you know, when I did the surgery, I had the anesthesiologist, a veteran anesthesiologist, not his first day on the job. This doc is a phenomenal doc, A+, outstanding, truly the nicest doctor. He's been in the operating room for almost like 30 years in the phenomenal training. He's part of the administrative committee, whatnot else. I have had nurses working since 2001, the surgical techs. They lined up once I did that Facebook, the first one from 1976 implant, and they were like, their jaws were dropped. They're like, what is this? We've never seen this before. And the point here is I made it a point so I can teach them, because they will go ahead and teach someone else. And I make it a point such that I can at least teach someone in the medical field what I know. Hopefully doing this Facebook Live, someone else can see the videos and they will speak for themselves. There's really not much talking to do, because you will see why implants are not good. They only hurt the body. No one comes into my clinic and says that implants are making me healthy. They only hurt the body. Look at the FDA warning. Number one, they said the implants only last 10 to 15 years. Number two, the implants are associated with lymphoma, even believe it or not, the smooth ones. And number three, that they're associated with breast implant illness. Who would want something that has all these negative side effects? Would you want to, just hypothetically speaking, invest in a house or a car and there was a warning that stated that you're only going to get this house for 10-15 years? Of course not. And if you're a young lady in your 20s, you can only imagine how many times would you, plus all the other problems, complications, and the problems that the implants cause. And as I have stated, number one, the compromises the pectoralis muscle, so the anterior shoulder support is gone. Number two, you compromise the quality of the mammograms, so they're not done ideally. And number three, you have basically the capsular contracture, infection, asymmetry. Today I did a case that had a double bubble where it was a technical problem by the surgeon and the implant was drooping down right at the level of the skin. So not even the fatty tissue was holding it. So you can only imagine the discomfort that the lady was going through. So the implants are only replete with problems, and I'll say this, there needs to be a halt to augmentation so that all of this breast implant illness, the problems that the patients are living with, are addressed, and such that we cause no more harm and no more pain to the many who have implants and who do not know that breast implant illness exists. And I will tell you, if it did not trust me, I would be augmenting, because there is no reason. And again, just going back and looking at my YouTube channel and the many pictures and videos, it will not take but a minute to be convinced that the implants are, and sorry to use this but very appropriate word, evil, and they do not belong in the body. I have a next question. When you say 4-minute shower, is that just only getting the incision wet for no more than... So the suture itself, as you can imagine, if you put your hands in water, for example, you're going to find that the skin gets really soft and it gets wrinkly. And, the suture that I used is We don't want water to hit it. It's water sensitive. Remember, it gets hydrolyzed. And I do not want, the next thing you know, if you take a longer shower, for example, the patient twists and turns and is getting the garments on, it may prematurely spread open. I want the sutures to be sitting there. And a 4-minute shower, I come up with that rule because I don't want water to be hitting and basically softening up the skin. This is ample time. I don't want people to be bathing for that reason or going swimming. And I'm very particular about this. There are plenty of times where I've done a lot of hand, arm, face reconstruction, and the next thing you know, the patient goes swimming. And for example, person was swimming, and then all of a sudden, let's say someone who's 2 weeks, 3 weeks out wants to go swimming, and then they want to get back on the kayak. And the next thing you know, because they were in the water, the skin is so soft, and they rub their chest against the boat, for example, or the kayak. You can only imagine it will not take much to rip what would be, despite the 4 suture reinforcement, the skin, because essentially you have suture that's holding it, what would be a very involved surgery, as you can see. This is a surgery that if you were to go to 100 plastic surgeons, I would say with confidence 90% of them would not even want to attempt, from what I hear and the feedback that I get from the community. And you know, they say it's not justifiable, it's not required, and the point here is we want to go ahead and follow through. So the 4-minute is just for the 4-minute shower rule. It's kind of my safety net where I don't want excessive water, but water that is going to clean, soapy water that's going to run over, and you can gently massage around the breast area. That's going to help clean the area, and then you can massage the incision and also the entire chest. And the reason behind that is when you massage, you, number one, right over the incision, if so, this line right here, this crease is the incision, you massage gently and in a circular motion and back and forth, and then the entire chest breast area. And so when you do that, especially over the incision, you calm those nerves down which were cut, which went haywire, through which those microscopic nerves. The second thing what happens is you stimulate nerves to come in an orderly fashion towards the incision. And number 3, you're going to find that the sutures are placed such that the skin is everted, and over the next year or so, the first 3 months, 4 months, you're going to find that it's going to start settling. An incision truly takes 1 year to settle, so that it will settle down nicely. And so that helps with the with basically the incision care. And this is not only true for my incisions at the crease, but also the thyroid or the C-section or any incision, and also any scratch or any abrasion in any part of the body. There is a nice YouTube video on scar management that I have, so if you want to listen, it's a little bit lengthy, but I talk about scars and the different ways of reconstruction. So, you know, one thing that I get is, you know, we don't have a definitive diagnosis, for example. You know, there's no lab workup that's done that shows, oh, you have BII. But, you know, it doesn't take much to that questionnaire that, you know, Jennifer sends out to my patients that lists all the problems from brain fog, fatigue, joint pain, autoimmune issues, the vision problems, the numbness, tingling in the arms, the throat clearing, vertigo, ringing in the ears, and all those symptoms, you know, from acute cystitis, GI issues, vision problems, all of the symptoms. Now, I say to you, yes, we don't have a lab diagnosis. We don't have an imaging diagnosis. But the 48-year-old or the 28-year-old that comes in and you have almost all these organ systems checked off, and you have no diabetes, no lupus, no rheumatoid, no Lyme, none of these other rheumatological problems. This is classic pattern recognition of what is breast implant illness. And this is where when I talk to my patients, I ask them, what % chance do you think you have breast implant illness? And almost a good number of them solid, 100%, because what else would it be? My doctor says I have in good health. And then what you hear repeatedly from the doctor saying, well, you got fibromyalgia, you're old age, you're 65, you got too many stresses in your system, in your life, you're just getting old. You know, this was told to another 33-year-old patient, you're getting too old. You know, when you're 33, you multiply that age and still add 15 years, that's the current age of our president. You know, so the point here is, you have this pattern recognition that gives you a complete, definitive, certain confidence level that this is breast implant illness, because what else would be causing vision, the headache, the neck and back pain, the teeth decay from the dryness that it caused, not only the eyes but the mouth, and then the rest of the body that we know from that study of studies out of MD Anderson that we'll put forth again on the Facebook page, that looked at 100,000 patients. That was a study of studies, 80,000 of which had silicone implants. And the point here is they all had these, what is the rheumatological connective tissue, dryness of the eyes, all these other issues that were a part of breast implant illness. So the point here is the breast implant illness is a defined problem with a defined solution. And the solution is where you see the many patients right within the recovery room or on their drive home are feeling better. The joint pain, rheumatological problems, face changes, eye changes basically occur in a very expedited way, some sooner, some later. And everybody's different. And I tell each one of my patients, once the explant is done right, then only we will see how and where your body is going to bounce back. I don't promise them anything except for the fact that you're only going to be better and healthier, and the patients almost all know. And as you have heard me say this on the previous Facebook Lives, almost all the patients that come my way, if not all, 100% of them have said that if they were to go back in time, they would never have gotten augmented, they would never have gotten the implants, and number two, they had wished they had removed it sooner so that they would have gotten their life back sooner. So when you say you do not augment and implants that are no good, do you use implant silicone devices or other regions? No, I do not. For a genioplasty, silicone implants very common. I did a nice lady from California approximately 2 months ago. She had breast implants, silicone, and also she had calf implants. So she had silicone implants within her calf. So right below the knee joint, they went in on the medial side of the gastrocnemius superiorly. They put an implant to kind of give more definition and shape to what would be the lower extremity. Some people complain of skinny legs, so she ended up getting calf implants, and so I removed those along with the breast implants that one day approximately 2 months ago. So this was a unique case that I did. And again, same problem, silicone, and then the body reacting to it. And so very important to basically not place anything that the body may recognize as foreign. So do you follow up with your patients? So absolutely, at the 6-week mark, I talk to the patients. Most of the feedback that you see, very nicely, are the patients that at their 1-year anniversary or 6-month anniversary, and I want the patients to do so, where they basically state, because this is all what we have, quote, going for us, right? It is the anecdotal, i.e. feedback on my Facebook group and the other Facebook groups, where you see the patients bounce back, you see their before and after picture. So absolutely, I do the follow-up with my patients at the 6-week mark. I say, how are you feeling better? The patients themselves describe, that they got their life back. I don't necessarily follow them at 3 months, 6 months. I was telling my staff, and my staff was asking, do you want to go ahead and do a study of all your explants and see what they did? And I said, that is at least a 1 or 2 man project. Plus, in order to do a study, you have to have like the IRB, where you have to have a very defined questionnaire, very objective. You have to have a big number pool of patients and patients that will respond. And I'll tell you, all what needs to do is follow up on the Facebook, and you will see the many patients from all over the US, and the many patients that I've operated on. They are very good about coming back and discussing and sharing all their many pictures of how athletic they have become, how energetic and lively they have become, how they have lost so much weight, and their lives turning around for the better and completely becoming what they were minus all the toxins of the implants, and different individuals. I have had a patient that came to me on a wheelchair, and she literally was in pre-op on a wheelchair, and the very next day, 24 hours, she walked into my clinic. And you will see the patients themselves attest to the fact, and they have nothing to gain except for their health and the betterment of their many sisters who are basically hurting. And not only that, but the rest of the significant others, the kids, their friends, and everyone around them, because this is a real problem that steals from the youth and from the health of not even the youth but the elderly, the patients in their 40s, 50s, and 60s, and look, the 70s. I asked the lady, why are you coming to me now? The nice 72-year-old that I operated on, and she had the shooting pains go up the left shoulder. Who wants to live with that? And the point here is, there is this silent phenomenon. No one knows when the silicone is going to rupture. I've had patients with the gummy bear at the 3-year mark where they had a ruptured silicone. This nice lady from Kentucky, and she's a young lady. She, at 3 years into her gummy bear implant, had a rupture. Right done. Facebook and a video that's on my webpage and my Facebook private group page. And the point here is, you never know when the implant is going to rupture, and we know this with certainty. The many studies that have been done, that as the years add on, the chances of a rupture go up exponentially, especially after the 10-year mark, even with the newer generation implants. And look, the FDA warning, the first item that they write, they are meant to be in the body for 10 to 15 years. And most of the studies stop after that, because they know that, it would be very scary to see at the 20-year mark how many implants are ruptured, especially the silicone, even the newer generation ones. So the number one is, what do you suggest for the women to do if the surgeon does not remove the full capsule? Now, I will tell you, you need to very selectively, the patient needs to do their homework, and they need to ask assertively, but very nicely and appropriately, what and how and what the take is of the surgeon in regards to BII. If they believe in BII, how many of those cases have they done? Do they have a track record of patients? I tell my patients, the single most important thing that you can do is to ask my old patients what happened, how was their surgical experience, and what is expected. It takes the anxiety away, and this is part of true informed consent. Going into your surgery, the patients are actually relaxed because you know what's coming. Same thing, you need to go talk to the old patients, so you know with definitive certainty. You may have the world-class plastic surgeon who knows how to do micro better than anyone else, but if they don't believe in BII, it's not going to be the right surgery, period. The whole commitment is to removing the entire capsule plus any inflamed tissue. And the point here is, your surgeon should be enthusiastic, very proactive, and should have a continued check and balance from the patients, the previous patients that he or she has operated on, such that you have that comfort level. Now, it's very easy now for someone, and this is what I was saying to a couple of Facebook lives ago, write a check to one of these Facebook group owners and you get promoted all of a sudden. Believe it or not, it happens. We all know that. There's no doubt that happens. And it is unfortunately wrong, unethical, unprofessional, and wrong in every regard, that the surgeon must earn his reputation, not through money, but through his own hard work and the feedback of the patients. I've given $0 to anyone, and I've had a lot of these, I have a lot of these texts that I've gotten, and Facebook requests, and Instagram requests from members, and say, oh, we will promote you, we believe in you, we will highlight you, we will get your videos, we have these many thousands of members, and we'll promote you for good discount rate. We'll start you off with this number, and we'll get these many videos out for this amount of dollars. And I'd say that's pure utter garbage and unprofessional and unethical, and shame on these where you're basically being promoted, especially when you don't believe in breast implant illness. And sorry to be rough, but I speak my mind, as you can imagine, especially when the surgeon is not a believer in breast implant illness. Let me go ahead and read another question, and then after that I will go ahead and start winding down. Yeah, so you know, the bottom line here is, you know, this is an involved surgery. And I get one of the questions from one of my patients. You know, it is very hard. You know, I will mention this. I have had I have 5 screws on my little finger. I was involved in a car accident. I had a cast on. And I will tell you, it's the hardest thing on earth to not use your arm, right? Especially when you're used to using it every single day, and when you're dependent on yourself and you don't want to be dependent on someone else. You know, it is very hard for someone post-operatively to be T-Rexed. I totally get it. But I want you to understand, look at the videos that I've put forth, right? Especially on YouTube, and now that we're putting up more. Look at all the void, the space. You can see the beating heart. You can see the raw rib. You can see the intercostals, right? You can see like the big void. Now all of a sudden that muscle is healing. This is a surgery, like I mentioned earlier, vast majority of the surgeons feel uncomfortable doing, and very appropriately. 90% or so, I would say, where they would say it's not required, it's unjustifiable risk. And it is certainly an involved surgery. The recovery period is also important. And once you let the chest heal and all the 6 weeks have elapsed and the settling down, i.e. the healing phase has occurred, where all those lifting up the mug of coffee, for example, or making the sandwich or the iPad was passive back and forth, and the muscle has settled down where you truly have not used the pec, then we can actively build on the muscle. But during the first 6 weeks, and especially the first 3 weeks, and you know, after the 3 weeks, it's not that the next 3 weeks you're going to find yourself you're doing a lot more, but as time progresses, you should basically kind of be very guarded, conservative. Should I or should I not do it? Err on the side of not doing it, because we want to let it heal. Once it has healed, then we will actively build on the muscle, because any movement will cause a stretch of the muscle, and you're going to find that that irritation, the shear forces of the skin and all that void where the movement is occurring will cause basically a stress on the incision. It may cause some of a discharge by gravitational force alone. You're going to have basically a pull. Let me give you an example. You operate on the nose. You break the nose and you do a rhinoplasty. You see the patient in a week, the nose is twice the size. 2.5, 3 weeks, 4 weeks, the nose is still very large, 30%, 40% large. At the 6 week mark, you're going to find, even after the fractures that I've done, I've put a lot of pins and screws in the hand, on the face and the rest. At the 6 week mark, the healing has occurred to the point where you can start using your arm. The bone has healed and the muscle has healed, and essentially a good phase of recovery has occurred. Then you can go ahead and start using your pectoralis and start moving and utilizing your chest muscles such that you can build upon it. But anything that you do will prematurely hurt, stress the incisions in the pectoralis and amongst all the tissues, the settling down, and you don't want to be in a situation where you are compromised and your recovery is delayed. So it is important to follow through. This is just like saying you get a knee replacement and in 2 weeks you decide to walk on it. You know, only going to hurt yourself. So the other thing I want to mention here is, you know, my patients will attest, you know, I truly, it's a privilege and an honor and a joy. As you can see, when I talk to my patients, I really get to know my patients. They are every patient, just like I myself, every patient is a personality. God has instilled in them their own thought process, uniqueness. They have their process of where and how they're coming from, their comorbidities. I get to know my patients. This offers a personal attachment to my patients. I spend time with them to the point where I get, oh, you got 3 people, 4 people waiting, and I don't see any more than 12, 15 patients in a day. And the point I'm trying to make here is the patient should feel comfortable signing up with you and vice versa. I've a patient that came, I said, unfortunately, I will be honest, I said, I'm sorry, I'm not your right surgeon. This happened to another male patient who came to me. I said, I'm sorry, I don't think I'm the right surgeon for you, and for the patient's own good. And the point I'm trying to make here is, it's not a matter of I'm booked 6 months out, or I want each and every single patient to feel comfortable signing up with their surgeon, and that they get the personal attention and feedback just like you would had you been the president of the US. And this is true for everyone. Now, that is certainly not achievable, but at least a sincere effort must be made in order to achieve that personal commitment, because that's what it takes. This is a very subspecialized topic that I will tell you the vast majority of the world does not comprehend or understand. No textbook will discuss this. No textbook will talk about it. Not even what I would say. I'm starting to see some paperwork that's come through. There was a presentation by Dr. Feng, for example. But this is something that's very much still in its infancy, but relatively very well defined. And the point I'm trying to make is this: you should, as a patient, be well informed and feel comfortable, and you should get that sixth sense feedback. I'll never forget, I've mentioned this on my Facebook Live before. There was a young mom of 5 kids from South Dakota. She came to me, and in 3 minutes, 4 minutes from the time it took for me to leave my clinic and go to my car, she's like, I'm coming. I said, I want you to ask me more questions, because you know what, you probably change your mind the last minute. And she said, no, I'm telling you. I said, then she said, there are 2 things. Number 1, what you talk about on your Facebook, on your YouTube, that no one will talk about this and speak the way you do. And I say, this is what you want to get, where your sixth sense, you feel comfortable. Number 2, the fact that you as a board certified plastic surgeon do not augment, that kind of seals the deal, because after this, what else am I looking for? And this is basically precisely where the surgeon, I myself, and amongst the others who have committed to not augmenting, they have taken a financial hit, which means that you would be making a whole lot more, at least 3 times, I would say, statistically, from what I see, because of the level of time and commitment, had a surgeon been augmenting versus explanting, right? Because explanting in itself is more involved, dangerous, and you would rather be done with 3 more augmentations in the time it would take for a surgeon to explant 1. And the point I'm trying to make here is, you need to have that sixth sense that your surgeon is going to do the right surgery, because you don't want to be that patient who's going to redo or get that surgery done, or the surgeon says, well, I did my best and unfortunately I left the capsule behind, which is unfortunate. The surgeon must have that expertise and that commitment that the bounce back of the patient is dependent on the surgeon wholeheartedly, faithfully. Just like when you remove cancer, obviously, in the same level of commitment, you're going to remove the whole thing, because that is what the bounce back is, the end. As simple as that. So with over the muscle, so my best patient, if you ask me, where patient comes in, and my best patient is the patient who is compliant, listen to my instructions that I give, who has saline implant, because if saline is ruptured, you know that she would be flat chested, and who has a set of saline implants above the muscle, because that means I'm not dissecting off of the rib. That means I am directly below the breast tissue and above the pectoralis. Automatically, the muscle is not touched. Because the muscle is not touched, the recovery is faster, better, less painful, and the patient can start using the muscles. Now, I don't have my patients above the muscle explants kind of start using their upper extremity, because when you start moving, you have the skin that rubs against the breast tissue and the muscle. I want that at least to have taken. That usually takes 3 weeks, so half the time period. And then I have the patients basically be actively working out, because it settles relatively fast. Now, there's so many factors and variables that come into play. The age of the patient, what size of an implant. If the patient has a 250cc implant versus the one that I removed today, 550cc, very large implant compared to the short lady that was present with a small chest. Her recovery is very different. So some people are very fast healers. Some people have good elastic recoil. Some people have lateral displacement of the implants. You can imagine they're going to heal relatively different. So on average, above the muscle implant, you're healing in 3 weeks, and in the next week or two after, you feel like so much better, and as far as movement and everything. But I still have it restricted and limited because I don't want shear forces of the chest moving in what would be that third space. I want that to have healed before I want my patients to start moving the upper extremities. But no muscle is cut. No muscle is involved. No muscle is part of the equation, so the recovery is relatively better. So what I want each and every one of you to do is ask and talk to the patients. You have 4 sets of players in all of this. You have the manufacturers. They're going to still, what they promote in the journals that I get, the implants are safe and effective, and I would say they're certainly not safe, and they're basically defective is what I would say. So absolutely, implants, the manufacturers are not going to talk about this. They're only going to promote they're only good. Number 2, the FDA. The FDA is kind of at a snail's pace, put out what would be the ban on the textured implants, slowly put out this warning about the 3 things, what is breast implant illness and the BII, and the lifespan of the implants. The plastic surgeons, unfortunately, are not talking much on a very hot topic, where, as you can imagine, from what I last read, augmentation used to be by far the #1 most common procedure done in the US. Now it is no longer the most common procedure, and many thanks to the many ladies who are actively talking about it on social media and spreading the word, where people are now canceling their augmentations, very appropriately so, because the word is getting around. And you have now state legislatures potentially talking about what would be the black spot warning, and patients Googling and seeing the horrendous negative effects of the implants, and the patients themselves deciding that augmentation is not a wise, smart idea in any regard. And now you have the last set of people are the patients themselves, and they are talking in the masses. They are communicating and they're discussing, and they now have this leadership role where they're now educating themselves and now going before the surgeons and the docs, the primary care doctors, and telling them what is breast implant illness and telling them to go ahead and study. And you have now what is literature that's coming out. It's talking about breast implant illness by the rheumatologists, by the many other doctors. Just yesterday, I talked to a lady. Her primary care physician did not want her to get implants. So you can imagine that there is a push, and it's starting to be 2.5, 3 months ago, a patient went to the emergency room, and I mentioned this on my last Facebook Live, and the emergency room doc said, patient went in for shortness of breath, and the emergency room doc very appropriately did a CT scan and worked her up. And and the emergency room doctor told the patient, you got bronchitis, but officially he said, you have implants, you have breast implant illness, I want you to go to Khan, and I strongly suspect this is what you have. You need to get the workup, that you have had the CT and the rest of the lab workup, but ultimately, what else would it be on a young lady? And this is and he said I could not list it as a diagnosis because there is no diagnosis, but chest pain / bronchitis is basically what she was diagnosed, and she was appropriately referred to, and she did her research, and she's like, that's exactly what I have. A young lady who checked almost all the boxes on that questionnaire that I have in my practice, and she's like, of course this is what it is. And this is where she now understands. There are millions of ladies who have not heard of BII yet. I was basically on the news on the Grand Rapids part of the state, and these are the ladies who are not Facebook savvy like myself, or they're not used to Instagram, and lo and behold, their main input is the news, the nightly news, and this is where they heard about BII for the first time. And the point here is the more we write, and again, what we're doing is educating the masses such that they are aware that there is hope and there is relief, and there is a real entity called breast implant illness, and there is a real solution for it when done right. And we have the anecdotal evidence and hopefully more scientific evidence where we have more leadership that will step up and take the challenge of doing more of this studying and hopefully putting a halt to what is augmentation, i.e. with silicone and or saline implants, both, because both are equally destructive. Now, having said this, until we meet next time, what I'm going to plan on doing is I'm going to actually bring on a guest, one of my patients. When I talked to her last, she said she has, quote, complete resolution of her breast implant illness. I will talk to her in regards to her experience coming on, how she did her research, what she basically how she did her homework, what types of questions she asked, what was on her mind, how and what her surgical date was, from all the pregnancy test that's done to all the going over the history, the detailed physical exam along with the history, going over the paperwork and the post-op expectations, so that we can learn from her, and hopefully that will be kind of an interesting way for my prospective patients to see what her explant journey was. Because just like many of you nice ladies, you want to talk about it. There was another significant other who had seen all my videos, and he was very much on board about what is explantation and why I do and how I do the surgery. It is a topic that if you look into and research, like I was telling one of my other prospective patients who I'm going to be operating on soon, if I give her a marker and a board, she can get on the board and she can give a lecture on breast implant illness. This is how well she had understood in just a few weeks of what is breast implant illness, given the research and her inquisitive mind. So having said this, I want to talk about, just real briefly, many patients have asked me about the vaccine. I want to go ahead and expand on this. The COVID vaccine, I am a biochemist from my undergrad, so and I understand medicine, given the fact that I'm an MD and a general surgeon, board certified general surgeon, and a board certified plastic surgeon. This is very interesting. And the fact that the COVID vaccine, the way it was developed by Pfizer, Moderna, and Johnson & Johnson, and the many other countries, for example, China and India, how they the many different countries, how they have made for example, synthetic or basically part of the virus. Overall, I have had friends of mine, plastic surgeon friends of mine, who've been on a ventilator, and luckily they were able to make it. My own uncle, unfortunately, God bless his soul, passed away taking care of COVID patients because of COVID. COVID is a real problem, and it is unfortunately here to stay for some time, and there might be other variants of COVID, Delta, amongst others, that are going to come our way. It is a whole interesting story. Everyone, I respect your rights and your wishes. You need to do your homework, just like with BII. But if you ask me, as a physician, I would say it certainly has given me the confidence, at least the 100 million and how many 100 more millions of people who have had the vaccine, where they're at least not on an ICU ventilator. I was very hesitant at first to get the vaccine. I did not get it right away. I waited 3 months for the millions of other people to have gotten it because of my history, because of my sensitivities and my body, the way I perceive what is the fastest vaccination development in the history of mankind. And the point I'm trying to make here is, given the risk versus benefits, I chose myself to get the vaccine for my own protection and the protection of everyone that I'm around, since I go to the hospital, the emergency room, and I'm always around sick people because I'm an essential provider. I was at the hospital when there was this entire lockdown. I was operating on patients, and I was truly basically exposed in one way or sense because of walking into the hospital, especially when This was the task that I had, given the open fractures and other reconstructions that I had to do, along with explants that I did actively during the shutdown, where there was no elective surgeries, and I was doing surgeries basically at the main hospital on explant patients. For example, explant surgeries on patients during the COVID time, when there was no elective surgeries being done, because the hospital recognized explant surgery to be essential and to be non-cosmetic in nature, and everyone knew that Khan does not put in implants, and that I had the green light to proceed with explants. And again, the point being, the medical community is very appreciative and very understanding once they're made aware as to why and what we are doing. And the point I'm trying to make here is, going back to the COVID vaccine has shown to work. You know, there are future implications, i.e. as to what's yet to come. I personally chose to get it, and hopefully, we all remain safe. The key here is washing the hands, the mask. This is kind of an advanced flu, just so that we protect ourselves and also our loved ones, so that we basically don't fall victim to this. And at least from what I see, we basically benefit from what would be the vaccine, and not fall prey to what would be something that may have long-term negative effects, from what you have seen. Well over half of the patients who have psychiatric issues from anxiety, amongst the many journals that have put forth a lot of studies on a lot of patients, including lung problems, chronic lung issues that the patients have had who have had COVID, amongst DVT and other issues that truly I cannot even comprehend, because there are so many variations, and how we're still learning more about what is, unfortunately, the COVID-19 experience. So having said this, I wish everyone the absolute very best. Take care, and please share the video if you can. Please ask questions, and hopefully till next time we meet again, all the very best, and God bless you all. Thank you again. Bye-bye.